One promising immunotherapy clinical trial for mesothelioma is a phase 2 trial testing the combination of nivolumab, Opdivo, and ipilimumab, Yervoy, in patients with unresectable pleural mesothelioma. Nivolumab is an immune checkpoint inhibitor that blocks PD-1, a protein on T cells that helps tumors avoid detection by the immune system. Ipilimumab also targets an immune checkpoint by blocking CTLA-4. By blocking both PD-1 and CTLA-4, this combination aims to more strongly activate the patient's anti-tumor immune response. The trial is enrolling patients with unresectable pleural mesothelioma who have not received prior systemic chemotherapy. Patients receive nivolumab 3 mg/kg every 2 weeks plus ipilimumab 1 mg/kg every 6 weeks for up to 2 years or until disease progression or unacceptable toxicity. The primary outcome is objective response rate assessed by investigators using RECIST criteria. Secondary outcomes include progression-free survival, overall survival, safety, and pharmacokinetics. As of November 2019, 66 patients had been enrolled and initial results found an objective response rate of 22% with the combination, including a complete response rate of 5%. Median progression-free survival was 7.5 months, which compares favorably to historical controls with chemotherapy. The combination also appeared to have a generally tolerable safety profile. Based on these promising early results, further studies are evaluating this immunotherapy approach. Another ongoing clinical trial is testing a vaccine made from a patient's own tumor cells combined with an immune adjuvant called BCG, Bacillus calmette-guerin. Mesothelioma tumor cells are taken from the patient's own tumor during surgery or biopsy. They are then irradiated to make them unable to further divide and grow but still able to be recognized as foreign by the immune system. The irradiated tumor cells are mixed with BCG to further activate dendritic cells and other components of the immune response. This personalized vaccine aims to train the patient's immune system to recognize and attack their own cancer cells. The phase 2 trial is enrolling patients with resected stages A3 malignant pleural mesothelioma with no evidence of disease after standard trimodal therapy involving surgery, chemotherapy, and radiation therapy. After recovery from surgery and adjuvant therapy, patients receive 4 doses of the personalized vaccine over 12 months along with BCG at months 1, 3, 6, and 12. The primary endpoint is to evaluate the safety of this vaccine approach. Secondary endpoints involve assessing immunologic responses, progression-free survival, and overall survival compared to historical controls. As of early 2022, the trial was actively recruiting with initial results still pending. Vaccine approaches hold promise for potentially maintaining long-term remissions in mesothelioma and warrant further clinical study. Meanwhile, researchers are also investigating CAR T-cell therapies for mesothelioma. One approach involves genetically engineering patients' T-cells to target the mesothelioma cell surface marker mesothelin. Mesothelin is highly expressed in malignant pleural mesothelioma but not most normal tissues, making it an appealing target. In a phase 1 clinical trial, researchers extracted T-cells from patients with mesothelioma. They then used viral vectors to introduce a chimeric antigen receptor, CAR, gene into the T-cells so they would produce an engineered receptor on their surface targeting mesothelin. After expanding the engineered CAR T-cells in the laboratory, the cells were infused back into the patients to help their immune system target and destroy mesothelin-expressing tumor cells. The trial is assessing the safety and maximum tolerated dose of this autologous CAR T-cell therapy approach given either as a single dose or multiple doses in patients with unresectable pleural mesothelioma. As of early 2022, 12 patients had been treated with preliminary results finding the therapy to be feasible and well tolerated with no dose-limiting toxicities observed at the doses tested. Some patients experienced stable disease as a best response, though objective responses have not been reported yet. Larger studies are still needed, but these initial safety results provide a foundation for optimizing CAR T-cell therapies against this challenging cancer. Researchers are also exploring combining different immunotherapy approaches. For example, one trial is evaluating the combination of anti-PD-1 therapy with a personalized mesothelin targeting vaccine. The aim is to generate an initial anti-tumor immune response with the vaccine while anti-PD-1 works to overcome tumor defenses against that response. This multi-pronged immunotherapy strategy holds promise for being more effective than single-agent immunotherapies alone for treating mesothelioma. Ultimately, continued clinical study of immunotherapy combinations tailored to mesothelioma biology may yield the most promising treatments for this very difficult-to-treat cancer in the future. There are a number of active immunotherapy clinical trials testing various novel immune-based treatment approaches for mesothelioma, from checkpoint inhibitors and vaccine therapies to personalized CAR T-cell strategies. Initial results have demonstrated feasible safety profiles with some early signals of activity, though objective response rates often lag behind other cancer types. Larger and more robust studies combining immunotherapy with other modalities are still needed. With further optimization and combination strategies informed by ongoing research, immunotherapies hold significant hope for eventually improving patient outcomes for this asbestos-induced cancer compared to standard chemotherapy options. Continued investigation of rationally designed clinical trials is crucial for advancing the treatment of mesothelioma through immunotherapy.